And so now we're going to talk about important considerations when switching to clozapine. I will readily admit that my two biases, if you will, in the treatment of patients with psychotic disorders, number one would be to use long-acting injectable antipsychotics liberally in patients who will accept this approach to treatment. And secondly, to use lots of clozapine when clinically indicated. Unfortunately, clozapine is dramatically underutilized. It has a number of potential serious adverse effects. There are a lot of hoops to jump through with clozapine, but I have seen tremendous success stories in patients who are treated with clozapine. It is our gold standard treatment for patients with treatment-resistant psychosis. And to the extent that we can use it, I believe that we will see better outcomes for our patients. So just as kind of my underlying perspective, I treat a lot of patients with clozapine, and I offer clozapine to anyone who, would meet those criteria. So that kind of segues to, when do we use clozapine? Well, I think there's kind of broad consensus between some different algorithms and expert consensus guidelines. So, for example, the Texas Medication Algorithm Project, or TMAP, for antipsychotics, step one would be a trial of a single second-generation antipsychotic. If the patient has a partial or non-response, then they should be tried on a different antipsychotic. And if they have a partial or non-response to an adequate dose duration trial of a second antipsychotic, step three is really clozapine. So similar to the TMAP for antipsychotics, the Schizophrenia Port Patient Outcomes Research Team Expert Consensus Guidelines suggest that clozapine should be offered to patients with schizophrenia who experience persistent and clinically significant positive symptoms, again, after just 2 adequate trials of other antipsychotic agents. And this really flies in the face of what we encounter clinically, and that is, I'll take a patient history and I'll ask, well, what antipsychotics have been tried in the past? And it's not uncommon for patients to name 5 or 7 different antipsychotics that have been tried with relative success or lack of success. And I'll ask, have you ever heard of clozapine or ever been tried on clozapine? And it's very clear that clozapine has not been discussed, despite the fact that they may have failed up to 5 to 7 different antipsychotics. It would be important to consider even earlier in this algorithm a trial of clozapine in patients with a history of recurrent suicidality, violence, or substance use comorbidity, which is always a remarkable thing because we think, given the need for blood monitoring with clozapine, these might be some of the patients who would be, least likely to be able to adhere to the monitoring guidelines, yet these are probably the subset of patients who need clozapine the most, as there's tremendous efficacy for clozapine in patients with violence and substance use comorbidity. But importantly, patients with persistent positive symptoms for at least 2 years warrants, and more than 5 years requires, a clozapine trial. I mean, let that sink in. It's really, in some ways, arguably malpractice to not offer clozapine to these patients with severe, recurrent, positive psychopathology. So, how do we titrate clozapine? The manufacturer guidelines would say that we would start with 12.5 milligrams once or twice daily. In my own clinical experience, I think it's fine to start a total of 25 milligrams clozapine on day 1 divided over 2 doses. That dose can be increased then by 25 to 50 milligrams daily, if well tolerated, to a target dose of 300 to 450 milligrams of clozapine by the end of week 2. Subsequent dose changes should be made no more than once or twice weekly, in increments not exceeding 100 milligrams. And of course, cautious titration and divided dosing are necessary to minimize risks of hypotension, seizure, and sedation. My own experience and kind of common approach with clozapine really depends on whether the patient is hospitalized inpatient or outpatient. So if the patient is an inpatient, I tend to start a total of 25 milligrams on day one, go up by 25 milligrams daily as tolerated, up to a dose of 100 milligrams daily. From there, I will go up by 50 milligrams a day, again to that target dose of 300 to 450 by the end of week 2. And I agree with kind of expert consensus recommendations not to make dose increases that exceed 100 milligrams. I would say it's much more common for me to make increases in intervals of 50 milligrams. Now, on an outpatient basis, if the patient warrants a clozapine trial, but we're managing them outpatient and they don't require inpatient hospitalization, I would say that my titration is a little bit slower. It can be confusing for many patients and families to try to change or increase the dose every day while at home. So my own clinical experience, I've found it's a little easier just to make dose increases on a weekly basis with each new prescription. So it might be 25 milligrams on week 1, 50 milligrams on week 2, 75 on week 3, up to 100 milligrams on week 4. And then from there, I would increase by 50 milligrams per week to that target dose. So what do we do with the pre-switch antipsychotic when we're switching to clozapine? So you may remember that I mentioned this plateau cross-taper switch, and that's kind of the general approach that we take when switching to clozapine. It's common to start tapering the pre-clozapine antipsychotic once you get to a clozapine dose of 100 to 200 milligrams daily. I usually feel pretty comfortable tapering the pre-switch antipsychotic when I get to a clozapine dose of 100 to 150. So it's not uncommon that when I make that next increase from 100 to 150 milligrams, that's when I start to taper off the pre-clozapine antipsychotic. And I would say that you can reduce the dose of the pre-switch antipsychotic really based on the patient's clinical response. So if the patient has persistent positive psychopathology, and by the end of 1 to 2 weeks, they've had dramatic improvements with a low dose of clozapine, then we can likely attribute that clinical improvement to the effects of clozapine. And so we can fairly quickly get them off of the pre-clozapine antipsychotic because the evidence would say that they really weren't responding to that agent. So one approach would be to reduce the dose of the pre-switch antipsychotic by 1/4 once or twice weekly. And again, with the speed of tapering being influenced by clinical settings. So as an inpatient, I think you could reduce the dose by 1/4 twice weekly, whereas with outpatients, it's probably easier just to make those dose reductions each week, especially if you're seeing the patient in clinic weekly during the initial period with clozapine. So there's really not much evidence in the literature to when and how do you discontinue the pre-clozapine antipsychotic. That said, if there's an urgent need due to some serious adverse effect, then the pre-clozapine antipsychotic should, of course, be stopped immediately. So a vignette here about how this might play out in clinical practice. So Miss M is a 30-year-old Caucasian female with a history of treatment-resistant schizoaffective disorder. She's failed 3 previous antipsychotic trials, 2 atypicals and 1 typical antipsychotic, both at an adequate dose and duration. While hospitalized for acute psychosis due to poor therapeutic response, she consented for a trial of clozapine. So she tolerated the initial dose of clozapine 12.5 milligrams twice daily. That got increased by 25 milligrams a day to a dose of 100 milligrams on day 4. Thereafter, her clozapine was increased by 50 milligrams daily over the next 6 days to a dose of 400 milligrams on day 11. And that was continued for the next week until she was discharged. And then starting at day 4, when she was on 100 milligrams of clozapine, her pre-switch antipsychotic, olanzapine, 20 milligrams, was tapered by 5 milligrams twice weekly until it was stopped 10 days later on day 14. Miss M had a positive therapeutic response to clozapine with improvement that was clinically significant both in terms of positive and general psychopathology. And, I think this scenario is not altogether uncommon when we're starting folks on clozapine. And this is kind of a clean example without significant adverse effects of how this switch to clozapine can be achieved safely and fairly rapidly. So our key points here: a trial of clozapine should be strongly considered in all of our patients with treatment-resistant psychosis using evidence-based algorithms and expert consensus guidelines. So I want to remind you that slow titration of clozapine, often with divided dosing, as well as gradual tapering of the pre-clozapine antipsychotic, is strongly advised.